All right, everybody, welcome back to the year's final edition of the High Yield Rapid Pharmacology Review. My name is Mike, and Mina will be talking to you a little bit later. As always, just a little disclaimer: we are sort of, I guess, we're flying by the hip. We're giving you what we think is most likely the highest yield information that it's going to be on your test on Friday. However, we're not working with anyone at school, so got to take everything with a mound of salt, not just a grain, because we're not going through everything that's covered in your lectures, and there may be things that we're leaving out, but we believe that the stuff that we're keeping in is the highest yield. So the next few lectures kind of revolve around the pharmacology of the clinical neuroscience class. And we're going to start with the anti-anxiety slash sleep drugs, which actually is very important, and it's something you'll see quite a bit in the future as your careers, patients coming in on medications like these. But sort of just to start out, sort of a very, very big picture, this kind of comes from a table in first aid, and it's sort of just drawing attention to the fact that some of the neurotransmitter targets that we're looking at for each of these different sort of disease states. Obviously, this is a little bit watered down. You guys probably know much better than I do at this point, having been out of this for a little bit and just working the different nuances of the different disease states. But just some examples, for example, anxiety, we have low GABA neurotransmission, low serotonin, high norepinephrine. For depression, I think it's a little bit better of an example, low serotonin, norepinephrine, dopamine. So when we talk about depression, we use serotonin and norepinephrine reuptake inhibitors to increase those kinds of transmission. In schizophrenia, obviously, we have high dopamine. We use dopamine blockers. OCD, we believe there's low serotonin. In Tourette's, we believe there's high dopamine. So not too important, but just to give you guys an idea of some of the neurotransmitters at play for each of the disease states. So I love this slide. This is actually one of my favorite slides because it was a slide that I had in my first pharmacology course. My pharmacology professor actually put this up, so I recreated it. I actually found the picture of a little chloride ion channel that's a GABAA receptor, and I found it, and then he actually had these exact things written down beneath, and I don't know, I just wanted to replicate it because I thought it was really good. So what we're looking at here is the GABAA receptor. And so as you can see, it's an ion channel. Chloride goes in, and then we have we have five, or a pentameric transmembrane channel. So there's five subunits. And so this is actually how like most of the receptors that you have are. It's not just a receptor, it's a conglomerate of different proteins put together that actually transverse the lipid cell wall. So there are many different subtypes of GABA-A, of the GABA receptor. We're focusing here on the GABA-A. And what's important to note here is that the alpha-1 GABA-A receptor subtype is linked to sedation and hypnosis, and the GABA2 and the GABA3A are linked to anxiety. So, there are different subtypes of receptors, so we can actually impact, we can try to isolate different receptor subtypes to try to get different effects. You'll see the same thing when we talk about the opioid analgesics. We're trying to, hit different receptors to cause them to do different things. It's also important to note that we have GABA that binds to the beta subunit of the receptor, but it seems here, I believe, that the benzodiazepine, located right here, receptor, is actually on the Y subunit, and that's very important because the benzodiazepines and the barbiturates act as, I'll use the term, allosteric modulators. They're not direct agonists. They're not going to the GABA binding portion of the receptor, like when we talked about norepinephrine and epinephrine, and then beta and alpha agents. Those are direct agonists. This is an indirect agonist. It's an allosteric agonist, so it's going somewhere else on that receptor to cause it to create a function. So it's very important to remember. All right, so we'll start with some of the bigger drugs, benzodiazepines. If you haven't heard of them before, you'll be seeing a lot of these for the rest of your career. There are many different kinds that are sort of broken down into the onset of action and duration of action. We have the ultra and the slash short acting, midazolam or Versed and triazolam. We have our intermediate acting, alprazolam or Xanax, lorazepam or Ativan. And then we have our long acting, chlorodiazepoxide or Librium, clonazepam or Klonopin, diazepam or Valium, and flurazepam. So these are all GABAA receptor modulators. As I showed you on the previous slide, these bind to the benzodiazepine allosteric site and provide modulation. So you're not directly activating the receptor. You're activating it through an allosteric site to provide modulation, and this increases the frequency of chloride channel opening. It's very, very important to remember that this increases the frequency of the chloride channel opening. You'll see the barbiturates increase the duration, I believe. We'll get into that in the future, and that's also something that's very highly tested on STEP. They like you to know that the benzodiazepine increases the frequency of the chloride channel opening. Uses used for many different things: anxiety disorders, sleep, anesthesia, alcohol withdrawal seizures, chemo-induced nausea and vomiting. So there are many different uses for benzodiazepines. Their indication is sort of what drives which one you're going to pick, because how fast do you want it to work and how long do you want it to work? So, for example, midazolam is a very commonly used induction agent for anesthesia because it is very fast acting. This would not be something that you would want for diazepam. You wouldn't want a patient to have diazepam because it would take a very long time for it to work. On the flip side, when you have a patient with alcohol withdrawal seizures, or if they're in DTs, delirium tremens, you would give them a diazepam or chlorodiazepoxide because you want a long-acting drug to activate those GABA receptors to reduce them from having seizures in the future. There's a very wide therapeutic index, so these drugs are relatively safe. However, I say that I don't want you to confuse and think that these drugs are, there's been a lot of stuff on the news. And the issue that we have with the benzodiazepines, which I'll talk about in the next few slides, is when they're mixed with different things like alcohol, opioids, and other CNS depressants, then they do cause severe sedation and respiratory depression. So in and of themselves, they're safe. They're, it's tough to overdose on these. However, if you take these in concert with something else, then they become deadly. And so it's very important to monitor for drug interactions with alcohol, opioids, or CNS depressants, or just to counsel your patients using other agents such as these that, there are some issues. Side effects, as we talked about, they are sedating. They can cause CNS impairment, motor and cognitive. Big one to know, respiratory depression, and then anterograde amnesia. So for chemo-induced nausea and vomiting, these drugs are actually used to induce amnesia of the event and then going forward in time. So for example, you would take this and you would take this before you had your chemotherapy session, and then you would have your chemotherapy session. So before benzos were around, patients used to be, I was told a story. A patient was in a grocery store, walking around and saw their oncologist, and, the memory of having gotten chemotherapy triggered them to just immediately start vomiting because some of the chemo regimens are so bad. So we use Ativan to actually help people, even there in that moment, sort of stop having the memory of the event. So they'll remember going and they'll remember going, sitting down, and they'll be aware of getting the chemo, but I guess in the future, after a couple of days go by, they won't actually have any recollection of the event. In addition, it's very important to remember that these drugs, you become tolerant to their sedative effect, but not so much their anxiolytic effect. So patients who are using them to sleep will unfortunately require dose escalation as they become tolerant to that effect. And then finally, you can withdraw from benzodiazepines. these are deadly. You can withdraw, and the effect that you would have is seizures, because as we're supplementing our GABA neurotransmission, if we were to take that away, all of a sudden we'd have a little bit of overexcitation because we were providing more of that inhibitory stimulus by supplementing more GABA. In addition, these drugs are highly addictive, especially the ultra and short acting ones that can lead to a little bit more euphoria and such. Z drugs. So these, as I was talking about before, are benzodiazepines that we were able to modify to specifically activate different targeted parts, different targeted receptors. So their mechanism is the benzodiazepine binding site. However, they are actually able to selectively activate the alpha-1 GABAA receptor, which, as I talked about before, are only linked to sedation and hypnosis. So we're just targeting sedation and hypnosis. We have zolpidem, we have zalplon, and then we have espiclozone. I can't pronounce this one. Azipiclone, whatever. Azopiclone. There we go. Azopiclone. This one is Lunesta, and the zolpidem is zolpidem is Ambien. I'm sorry. So just a few things about them. They all sort of have residual effect in the morning afterwards. Zaplion can actually be used very late at night. It's supposed to have a bit of a shorter half-life, so you can take one after you've already taken one, and it won't affect you too much. And then azopiclone is supposed to have little tolerance. It's supposed to, you're not really supposed to become tolerant to the effect of it. That's crap, but just know this for the test. Just a few little things about each agent. Side effects, the most commonly felt side effect is morning drowsiness. And so this actually extends to morning amnesia. And some patients have actually described waking up, or some patients have actually described just, it's 9 a.m., they're driving in their car, they don't know how they got there. Or, it's 9 a.m. and they're eating breakfast and they don't know anything before that. So these drugs, just because they're Z drugs and they're specifically for sedation and hypnosis, don't think that they're really any less dangerous than the benzos. These are quite powerful drugs not to be messed with. They do have a couple of other side effects like dizziness, headache, and GI complaints, but you do want to remember, as I just said, they do have some abuse potential. They are drugs that have some, they do have some addictive potential. Finally, they do lack the anticonvulsant, anxiolytic, and muscle relaxant effects of some of the benzodiazepines. We're just targeting sedation and hypnosis with the Z drugs. All right, so question. 43-year-old woman presents to the ED following a motor vehicle collision. She sustained no serious physical injuries, but appears drowsy and states that she's still very sleepy. EMS collects several open bottles from the floor of her automobile. Although the contents of the two bottles could not be determined, she recently filled a bottle of diazepam as almost empty. The patient becomes quickly unresponsive and stops breathing. What is the mechanism of action of the agent that could reverse her symptoms? All right, I have my answer. Which one do you think it is? I don't think it's D or E. We're not talking about glycine. It's got to be something to do with GABA. And we didn't talk about the GABA-B receptors either. So we're looking at possibly A or B. What do we think? If you picked a B, sort of by process of elimination, the competitive inhibitor, we don't want another agonist. We want to inhibit the GABA receptors. But that is flumazenil. And I hope it's like a nice little introduction into the benzodiazepine receptor antagonist or, reversal agent. So I don't know if we've talked about too many reversal agent yet. But for Tylenol, you're going to have to know it's N-acetylcysteine. For Opioids, we haven't talked about opioids yet. It is naloxone, and for benzodiazepines, you have to know it's flumazenil. So these are antagonists. This is an antagonist at the GABAA receptor. It's got a very short half-life, so antagonism will not last. You do need to, transport and get somebody stable and figure out other ways to deal with the increasing amounts of benzos in their body. This isn't this is a quick fix. It's not a long-term treatment. Finally, you could actually precipitate withdrawal and then seizures when giving somebody this, because if they are on a benzo, they are going to be supplemented through their GABA adrenergic. You're modulating the GABA adrenergic process. So if you stop that, all of a sudden the GABA inhibition is now the GABA's inhibitory neurotransmission is stopping. So all of a sudden you're having a massive increase in excitatory neurotransmission. So that could possibly precipitate a seizures. In addition, if you are mixing the benzo with alcohol, a barbiturate, or opioids, this will not reverse the CNS depression seen from those other agents. You do have to continue forward and figure out ways to deal with that. You may be able to reverse the benzodiazepine portion, but not the others. So, barbiturates. So these are GABA agonists and modulators as well. And it's very important to remember, at low doses, we're facilitating a GABA binding, but at high doses of barbiturates, we're directly opening the GABA receptor. And that's what I was going to come back to. With our benzodiazepines, we're increasing the frequency of the GABA receptor opening. We're modulating that. With the barbiturates at higher doses, we're directly opening the GABA receptor. Extremely important to remember. And it sort of makes sense. Our barbiturates are our stronger, much more dangerous, higher rate of side effect profile drug. So if we're directly opening the receptor, we're going to have a lot more problems than if we're just modulating it and we're allowing a more physiologic opening, but just at a more frequent time. So here are some barbiturates. We have phenobarbital, our long-acting. We have some short intermediate-acting, seco and pentobarbital, and then we have ultra-short-acting, thiopental and methohextol. So these are primarily used as anesthesia adjuncts and anticonvulsants. They are very rarely used anymore as anxiolytic and sedative. And that's because some of the CNS depression and respiratory depression was so strong, and that these drugs had very narrow therapeutic windows. So you could take a very little bit of this drug and have a lot of effect, and it was different from person to person. There were lots of interactions with other CNS drugs as well. As we talked about with the benzos, however, these were a little bit more dangerous. There is a tolerance effect to these drugs, and then again, withdrawal can lead to seizures. This is more so seen with barbiturates than benzos, and these are very high. These are drugs of abuse. They are very very easily abused, and they're these are one of our more regulated drugs that you can't just stumble upon in your I guess it's they're more regulated. They're much more regulated than some of the other drugs we've been talking about because of this high use potential. In addition, we've had a few cases. We talked about griseofulvin being an inducer of the CYP enzyme. We talked about rifampin being an inducer. Barbiturates are another inducer of our CYP enzyme. So we're actually increasing the amount of cytochrome enzymes. So if we have a drug that is metabolized through a cytochrome process, that drug's levels can be reduced if the patient starts on a barbiturate. So this is sort of what I was getting at before with the side effect profile. Benzodiazepines, as the dose increases, sort of plateau. Barbiturates, on the other hand, have this steady course into CNS and respiratory depression. So therefore, because of this, the benzodiazepines have this more safe side effect profile, therefore have sort of replaced barbiturates and are common prescription use of them for anxiety and hypnosis and things like that. However, when you start taking your benzodiazepine with an opioid, with alcohol or other CNS depressants, its side effect profile nearly mimics the barbiturate, and we have lots of overdoses. So when you ever hear any, celebrity or anything on the news about somebody who was drinking and then taking drugs and they died in their sleep, or they unfortunately aspirated, it's very, very likely that they were possibly mixing a benzodiazepine with alcohol, and that's what unfortunately led to them succumbing. Other drugs, buspro, very, very important drug to know, because of the fact that it doesn't have any abuse potential and it has no sedative properties. So this is our 5-HT or serotonin 1A partial receptor agonist. It's used as an adjunct or on its own for anxiety of mild or moderate intensity. It has some palpitations and tachycardia, GI distress, pupillary constriction with it, but the side effects you don't worry about too much. It also may have some D2 antagonism and cause some extrapyramidal symptoms, which we'll talk about in the future of this lecture. Don't worry about that too much. What you need to know, it has no tolerance. It's got minimal tolerance, and it has no sedative or abuse potential. So this is sort of the drug of choice in those patients who are coming in who have a history of substance abuse. That buspirone is actually very, very useful, and they won't want it, of course, because they're looking for a drug that you know has a little bit of they're sort of, when a patient comes in for anxiety, sometimes they're looking for something to give them a little bit of sedation, or they're looking for something that will give them a better feeling, or which is why they tend to gravitate towards the drugs of abuse, and then they'll feel as though buspirone doesn't have much of an effect because it doesn't sedate them as much. Now, I speak in generalities. That's not true all of the time. I've had a lot of patients who've had a lot of success with buspirone, but just something to consider. Sometimes, as we try to help our patients, some of the tougher ones who do have the history of substance abuse, they know about these drugs. They know buspirone. It's not a benzo, and so therefore they won't want to take it because they know it won't have some of those similar effects. It won't make them feel as good. So just to let you know, the patients are smart out there, and you're gonna have to be dealing with a lot of different characters. Okay, a few more. Trazodone. Trazodone is our 5 serotonin antagonist, or it's just our serotonin antagonist and our reuptake inhibitor. It also has alpha 1 antagonism and histamine 1 antagonism. So therefore, it sort of has this antidepressive at high doses, but what we primarily use it for is the sedative at low dose. So you can see especially in the H1 antagonism, our histamine blocker, why it may have a little bit of sedative effect. It's very anticholinergic, and in this case, in some cases, we're using it for sedation. But it can cause sedation as well. And then one of the big high yields is it can cause priapism due to alpha 1 antagonism. We also have a few adjuncts. Ramelteon, so this is a melatonin agonist. It's an agonist at the melatonin 1 and 2 receptors. It's used for circadian rhythm sleep disorders, which is mostly seen in patients who are blind. They're not really able to generate their own circadian rhythm. So I haven't really ever seen this used actually in standard. I haven't really seen this be prescribed, so I can't really speak too much to it. But I wouldn't worry too much about Ramelteon. And then there is the newest drug to the newest class of drugs, Sorvarexant. So this is an antagonist at the orexin 1 and orexin 2 receptor. And so the idea here is that instead of promoting sedation, we're reducing wakefulness. And so we're antagonizing wakefulness and therefore promoting sleep. So it works in a little bit of a different way. We're not increasing our inhibitory neurotransmitters. We're inhibiting our wakeful system through the hypothalamus. And so that's how this drug works. It's not really too well understood. I've never seen this out in the field, so I wouldn't worry about it too much, other than the fact that you want to memorize or just associate the name with the mechanism of action. Finally, a little bit of FYI, just to bring back that, we actually can use first-generation antihistamines like Benadryl and meclizine for as sleep aids. And so just tying back to some other drugs we've talked about, how they can be used for sleep. So just a little bit of a summary. For sleep, first-line interventions, just non-pharm. If you can't sleep after about 10 minutes, you want to get out of bed and do something else. You don't want to bring your computer or your phone into bed with you, and don't eat in bed, don't eat before, just general non-pharm stuff. Second line, you want to start thinking about your histamines, antihistamines, and melatonin. Next is when we start talking about our Z drugs and our trazodone. Finally, last line, we generally don't like to use benzos. You'll see them prescribed quite a bit, but it's because of the addictive potential, we tend to not want to use these to try to help people sleep. Just a little side note, narcolepsy, we can use modafinil, which is a stimulant agent to help you stay awake during the day. Okay, anxiety. So acutely, we can use benzos for patients having this acute attack. And of course, for all of this stuff, we're giving you sort of the shorthanded pharm explanation for things. I know they went into a little bit more depth in clinical neuroscience about the treatment for all of these different things. For clinical neuroscience, you want to stick to what they had said, but just for us, this is sort of just, FYI, what people can tend to use that we think, not classic textbook or wrote us in a lecture. So acutely, you can use benzos. You don't really, there's a lot of debate that a panic attack is a panic attack is sort of minutes, and if you take a benzo, technically it's not really going to work for about like 20 to 30 minutes, so the panic attack will most likely be over by the time you use it. So there's sort of a debate on that. Beta blockers, so that's more so for if you're a concert pianist and you're always nervous, or you have to give a big speech in front of your company, you can actually take a beta blocker, specifically propranolol, to sort of dull the sympathetic effect before having to do that task. Chronic treatment of anxiety revolves entirely around cognitive behavioral therapy and then SSRIs and SNRIs. Second line, we can use things like buspirone, bupropion, hydroxyzine, imipramine, and pregabalin. I don't know why all of this is misspelled. I apologize. I'm going to correct that on the PowerPoint that I post. And then there really is no particular order in any of those agents. Finally, the one thing you do want to know is, as I said before, if the patient is high risk for substance abuse or has a history of substance abuse. For anxiety, you want to stick to buspirone. Sorry, I can't speak right now.